others will join. Good morning. As part of our seminar discussion, we are trying to cover all the theoretical topics in different chapters. So we are not hurrying up. We are taking each of the chapter and making the main points to be discussed as a seminar. So today will be discussion on carcinoma of the esophagus. We have three speakers: Dr. Snehashi Shah from IPGM SSKM Hospital, third year PGT. Then Dr. Malavika Rao from Apollo Gleneagles Hospital, third year junior resident, and Dr. Anish from RKM. So Dr. Snehashi, you can share your screen and start. And today the session will be moderated by Dr. Somen Das. He is associate professor of IPGM SSKM Hospital. Now he is in charge of surgical oncology department at Netaji Subhash Bose Cancer Hospital. So Dr. Somen Das will be moderating the session today. So Snehashi, you can share your screen and start. Pathogenesis and risk factors in cancer esophagus.
Good morning, sir. Sir, I'll share my screen, sir. Good morning, respected faculties and my fellow colleagues. Am I audible, sir?
Yes, yes.
Good morning, respected faculties and my fellow colleagues. I'm Dr. Snehashi Shah from IPGM and SSKM, and I'll be presenting the etiopathogenesis and risk factors of carcinoma esophagus. Before coming to the etiopathogenesis and risk factors, we will briefly sum up the epidemiology of carcinoma esophagus. Esophageal carcinoma is common in China, South Africa, and Asian countries. In India, it is common in Karnataka and Odisha. It is the 8th most common cancer worldwide and the 6th most common cancer causing death overall. The incidence of esophageal cancer increases with increasing age, with the peak occurring in 6th or 7th decades of life. It has a male preponderance, with the ratio of male to female incidence being approximately 3.5:1. Dysphagia is the most common presenting symptom. Esophageal carcinoma is mainly of two types: squamous cell carcinoma and adenocarcinoma pathologically, and they have different features. Squamous cell carcinoma usually occurs in the middle third, with the ratio of upper to middle to lower being 15:50:35. And adenocarcinoma most commonly occurs in the lower third of the esophagus, accounting for 65% of all cases of esophageal carcinoma. Recently, there is an epidemiological shift from a squamous cell carcinoma to adenocarcinoma overall in Western countries, with an increased incidence of adenocarcinoma and a decreased incidence of squamous cell carcinoma. However, squamous cell carcinoma is the most common histology worldwide still. Now, coming to the risk factors for squamous cell carcinoma of the esophagus, they can be divided into different categories. There are some lifestyle factors. Among them, smoking and alcohol consumption are the most important, which individually increases the risk factors for development of squamous cell carcinoma. Intake of hot beverages also increase the risk factors. N-nitroso-containing foods such as pickled vegetables also increase the risk factor. Betel nut chewing is also an important risk factor, and a diet deficient in fresh green vegetables, fruits, and vitamins, and opium smoking are also implicated. There are some genetic factors implicated, such as mutation of p53 gene and cyclin D1 and EGFR mutations. Some microbial factors have also been implicated in the pathogenesis, such as the human papillomavirus and certain fungi belonging to Aspergillus group. Some other pathologies have also been implicated with development of squamous cell carcinoma, such as corrosive acid strictures, Plummer-Vinson syndrome, achalasia cardia, history of aerodigestive malignancy, and history of irradiation to the mediastinum. Now, coming to the risk factors for adenocarcinoma, The most important risk factor for adenocarcinoma is a pre-existing gastroesophageal reflux disease. As such, Barrett's esophagus is also an important risk factor for adenocarcinoma. Other risk factors are obesity, mainly central, smoking, history of irradiation to the mediastinum, and increased acid production conditions such as Zollinger-Ellison syndrome. Now coming to the pathogenesis of squamous cell carcinoma of the esophagus. The normal esophageal mucosa is exposed to multiple carcinogenic exposures such as smoking, alcohol, and others which have been already described. This leads to certain genetic changes such as amplification of the transcription factor gene SOX2, which leads to overexpression of cell cycle regulator cyclin D1 and loss of function mutation of TP53, E-cadherin, and Notch1. These lead to squamous dysplasia, also known as intraepithelial neoplasia or carcinoma in situ, which finally leads to squamous cell carcinoma of the esophagus. Now coming to the pathogenesis of adenocarcinoma. The pathogenesis of adenocarcinoma is mainly due to metaplasia of the normal esophageal mucosa. Gastroesophageal reflux disease causes metaplasia of the stratified squamous epithelium of the esophagus to columnar epithelium, leading to Barrett's esophagus. A metaplastic mucosal lining can proceed to varying grades of dysplasia, from low-grade dysplasia to intermediate-grade dysplasia to high-grade dysplasia, which can finally lead to occasionally the implication of obesity in pathogenesis of adenocarcinoma has also been studied, but it is not so well developed. Mainly abdominal obesity leads to hypertrophied adipocytes, which leads to environment of low-grade inflammation, and such an environment promotes tumor development through the release of adipokines and cytokines, which may lead to adenocarcinoma. And that sums up my presentation on etiopathogenesis and risk factors. Thank you.
Thank you, Dr. Snehashish. Just one point to mention, you haven't mentioned the H. pylori as a risk factor. So what is your idea of H. pylori as a causative agent of esophageal carcinoma?
So pardon, sir?
H. pylori.
H. pylori. Role of H. pylori in esophageal carcinoma.
Sir, H. pylori has now been implicated to be preventive in the development of squamous cell carcinoma of the esophagus due to increased due to the epidemiologically, it has been studied that the places where the incidence of H. pylori infection is more, the incidence of esophageal carcinoma is less. So it is now believed to be protective in the development of esophageal carcinoma.
So you see, this is true for adenocarcinoma actually. H. pylori, what it does? H. pylori causes atrophic gastritis.
Yes,
so atrophic gastritis will lead to less acid production. If there is less acid production, there will be less reflux. So that will prevent the lower esophageal mucosa to undergo Barrett changes. Okay, and we know Barrett is an important risk factor for adenocarcinoma. So that is why H. pylori infection actually reduces the chance of adenocarcinoma. Whereas H. pylori leads to atrophic gastritis, and atrophic gastritis will increase, will have a bacterial overgrowth in stomach. That will lead to increased formation of nitrosamines, and that will lead to increase in the chance of squamous cell carcinoma. So it decreases the chance of adenocarcinoma, but increases the chance of squamous cell carcinoma. Okay. And one interesting point on risk factor is on smoking. If you smoke, there will be increase the chance of both adenocarcinoma and squamous carcinoma. But if there is smoking cessation, will there be reduction of both the cancers, the chance of both the cancers, or will there be reduction of only one?
So with the cessation of smoking, I think the chances of the development of squamous cell carcinoma will be lesser than that of adenocarcinoma.
Yes, but the squamous cell carcinoma, because of irritation, it will go down. But adenocarcinoma, since the carcinogenesis process starts, even if you stop smoking after 8 to 10 years of smoking, the risk of adenocarcinoma will not go down. So these two are very interesting from risk factors. Okay, thank you.
Snehashi, expecting that you will also cover the pathology part of the Carcinoma esophagus. I mean, what are the different types of microscopic types, and then the spread. Okay, so this is also part of etiopathogenesis. So
Okay.
can you
So
just state what are the different macroscopic types of cancer esophagus?
So macroscopically, sir, they can be a proliferative type,
Yes.
in which there is a nodule which grows into the lumen of the esophagus,
Yeah.
or sir, they can be an ulcerative type in which there is an ulcer, and thirdly, there can be another type which is a stenosing type of a lesion.
Infiltrative type.
Infiltrative, or yes, sir, and which basically is a stricture-like pathology which leads to an overall decrease in the lumen of the esophagus.
And how does it spread?
So the lymphatic spread of carcinoma esophagus depends
First is
on the
direct spread. It
yes, sir.
starts in the mucosa, and
Yes,
then
sir.
there is a direct spread to
Direct spread to the other layers of the esophagus according to
and
increasing depth,
also
and also to the
it
surrounding
involves
structure.
vertically.
Yes, sir.
Transmural spread.
Yes, sir. And the lymphatic spread of carcinoma esophagus depends upon the location. For example, if it's in the cervical esophagus, it may spread to the cervical lymph nodes. If it's in thoracic esophagus, it may involve the mediastinal group of lymph nodes, and abdominal esophagus, it may spread to the gastric and celiac group of lymph nodes.
And blood spread?
Yes, sir.
It can spread by blood also.
Yes, sir, and it can spread by blood and to the lungs, sir.
Only lungs?
So liver.
Yes. Bones?
Yes, sir. Yes, lung, liver, and bones.
Right. One interesting point on the lymphatic spread and the direct spread is, you know, which layer is deficient in esophagus?
So serosa, sir.
Serosa is not there. So lateral spread is very quick, and interesting to note that the upper esophagus that spreads horizontally, the mid esophagus can spread upwards and downwards. The lower esophagus spreads to the lower part. So for a mid esophagus, a three-failed esophagectomy is a must.
Okay, sir.
Right.
Okay. We can pass to the next speaker. Dr. Malavikar, I will speak on the presentation and investigation and staging of cancer esophagus. Malavika, you can please share your screen and start.
Good morning, sir. I've sent Milind the slides.
Okay.
I'll be presenting the clinical features, investigations, and staging. The clinical features. In symptoms, they mainly present with
Malvika, you're not audible.
Oh, can you hear me now?
Yeah.
Okay. Dysphagia, the most predominant symptom for esophageal cancer when presents symptomatically is usually in the advanced stage, and it usually ends with dysphagia or dinophagia, which is solids to liquids. Other features of reflux like regurgitation, heartburn, and vomiting. Then features of the symptoms of advanced recurrent laryngeal nerve palsy, which presents hoarseness of voice, Horn syndrome, which is meiosis and hydrosis, loss of cerebrospinal reflex, and ptosis of the spinal involvement, chronic spinal pain, diaphragmatic paralysis, weight loss, which is more than 20% of body weight, and anorexia. Next. And if there is palpable lymphadenopathy, especially the supraarticular lymph node, and cutaneous tumor metastasis, this is indicative of an advanced disease and also an incurable disease, resectable disease. Investigations. First investigate contrast esophagogram on an usually earlier was done with barium enema, now can be done with a water-soluble contrast as well, which shows irregular narrowing and ulceration or ulceration. This is apple core filling defect, which and there will be proximal dilatation of the esophagus with distal tapering, sudden tapering, and irregular tapering. So that will have shouldering and also will have air fluid level in the proximal segment. And then upper GI endoscopy, which in earlier lesions will show ulceration or may show nodules, and more advanced lesions present as friable masses or strictures. We'll also be able to see the presence of Barrett's esophagus, and can also assess any the only limitation of upper GI endoscopy is that it can assess only mucosal and submucosal growths and cannot assess beyond that. Biopsies can be taken with upper GI endoscopy, and for T1A lesions and TIS lesions for Barrett's and Barrett's esophagus, endoscopic mucosal resection can be done. It can be done. It's a diagnostic as well as a therapeutic procedure. Then a CT or an MRI, which has similar benefits, from the neck to the pelvis, can show distant metastasis, can also show local invasion, lymph node status, and distant metastasis. Next slide. Bronchoscopy can be done for upper and middle third esophageal carcinoma, and if there is involvement of the trachea, it immediately shows unresectable tumors. Endoscopic ultrasound is a very useful ultrasound, a useful investigation, because it uses endoscopy as well as ultrasound and can assess the depth of invasion. Is the depth of invasion the three main prognostic factors is hematogenous for esophageal carcinoma is hematogenous spread, depth of invasion, and lymph node status. So EUS helps us to assess the depth of invasion of the esophageal layers as well as the adjacent structures, and can also also the lymph node status. It can also assess metastasis to the liver, and it can also take an FNAC along while during an EUS, which increases the accuracy of diagnosis. And PET CT, which 18 FDG, which can show metastasis, and also works as a baseline test to assess the response to neoadjuvant chemotherapy for esophageal carcinoma. And comes to the staging. Now we have the eighth edition of Ajcc Staging. The new edition has different staging for squamous cell carcinoma as well as adenocarcinoma. The TNM remains the same. The pathological and clinical classification changes. In the T stage, we have TX, which is tumor cannot be assessed. T0 is no evidence of tumor. TIS is high-grade dysplasia. T1A is tumor invading lamina propria or muscularis mucosa. T1B is submucosal invasion. T2 is muscularis propria invasion. T3 is adventitial invasion. T4A is into the adjacent resectable structures such as pericardium, diaphragm, pleura, azygous vein, peritoneum, and Yeah, and T4B is invasion in the unresectable structures, which is aorta, vertebral body, and trachea. And we have regional lymph nodes, NX, N0, and 1 is metastasis to 1 or 2 regional lymph nodes, and 2 is to 3 to 6 lymph nodes, and N3 is more than equal to 6 regional lymph nodes. Distant metastasis
Has to be 7.
7.
Then
okay.
7.
Okay. The next one. We also have histological grading, which is important, which is 1 to 3 shows progressive undifferentiation, and G3 is undifferentiated carcinoma. And for squamous cell carcinoma only, the staging also shows importance for the location, whether it is present in the upper, middle, or lower. Upper is defined as from cervical esophagus to the lower border of esophagus vein. Middle is from the lower border of esophagus vein to the lower border of inferior pulmonary artery, and lower is from the lower border of inferior pulmonary artery to the gastroesophageal junction. This is the TNM staging, which is depicted. This is for squamous cell carcinoma. And next slide, please. Oh, sorry, there's another missed slide. There's a different clinical classification for adenocarcinoma. The new features in Ajcc 8th edition is that squamous and adenocarcinoma, squamous cell carcinoma and adenocarcinoma have been differentiated in pathological and clinical staging. And this is also the first TNM staging which has clinical, pathological, and post-neoadjuvant classification in order to assess to stage them differently. Thank you.
Okay. So how do we grade dysphagia? Have you heard of any grading system for dysphagia?
No, sir.
Okay, so this is very commonly used in oncology practice, especially who are undergoing radiation for head neck cancers. So they have a beautiful staging. We grade dysphagia into 4 grades. Okay, so grade 1 is patient is having some difficulty with solid food. So he is able to take solid food, but with some difficulties. So this is a grade A or grade 1 dysphagia. Grade 2 is patient is unable to take solid food, but he is able to take semi-solid food. Grade 3 is patient is not able to take semi-solid or a solid food. He is only surviving on liquid food. So that is a grade 3. And grade 4 is when the patient is not able to take any form of food, be it liquid or it is solid. So how the dysphagia starts? Initially, is it with the liquid? What is the difference between a dysphagia of achalasia cardia and a dysphagia of carcinoma?
Carcinoma esophagus, dysphagia starts off with dysphagia solids and then progresses to liquids. Whereas in achalasia cardia, because of the pathological segment, which is where there is no peristalsis, there's proximal dilatation, and there is first dysphagia to liquids, which then progresses to solids.
Right. So, and what is the difference between the barium finding of a achalasia cardia and a carcinoma?
Achalasia cardia has smooth tapering, and it has the bird beak appearance, whereas in carcinoma esophagus, it is an irregular thickening of the irregular stricture and narrowing, which has shouldering and apple core deformity.
Right. So, would you compare CT with MRI in carcinoma esophagus?
In CT scan is more in terms of assessing for local spread, lymph node status, and metastasis. It is that they have similar effect, but CT scan is more readily available, and MRI doesn't expose the patient to radiation.
Right, but their sensitivity and specificity profile are more or less same. So,
yes.
what are the advantages of PET scan over CT scan?
PET scan will be able to. I'm not
What
sure.
is the
Sir.
biggest advantage of PET scan?
PET scan can detect lymph node metastasis, primary tumor, distant metastasis.
Distant. It has got an immense advantage of getting distant metastasis. So it has been seen is carcinoma esophagus. When you do a PET scan, in 15% of cases, it has upstaged the disease. And in 20% cases, it has changed your decision. Suppose you have planned for a esophageal resection based on CT, MRI, or US, you have done a PET scan. In 20% of cases, it has shown that the decision is going to be changed based on the PET scan report. That is, it has got an immense advantage of detecting metastasis in distant places. So that is the advantage. And endo-US?
Endo-US, we can see the depth of invasion into the esophageal wall.
T and N. For T and N, lymph nodal pickup is also very good with endo-US. Right. And tell us something more about the gastroesophageal junction.
So the surgical and the anatomical the physiological and the anatomical gastroesophageal junction are not perfectly aligned. Very usually the physiological gastroesophageal junction is usually a little lower down, in the distal esophagus, with around approximately a 4 centimeter difference. And the physiological one also shows the squamocolumnar junction. Yes, sir.
So in G junction, there are two ways of identifying it by doing an endoscopy, and there are two ways of identifying it while doing laparoscopy or open surgery. For endoscopist, there will be a sudden change from the smooth mucosa to the rugal fold of stomach. Okay, so that area is the G junction. Another way of identifying it, the color of the esophageal mucosa suddenly becomes reddish and velvety, which is a columnar epithelium. So that's change. And from outside, there is a collar of Helvetius and a pad of fat, gastroesophageal pad of fat. These are the ways how you identify gastroesophageal junction. But what is important for our purpose, that is today's topic, is the Seward classification. You know, because a part of gastroesophageal junction belongs to esophagus and a part of gastroesophageal junction belongs to stomach. So it's like Kashmir. There is always tug of war between stomach and esophagus, that which part belongs to esophagus and which part belongs to stomach. So in Ajcc 7, the Seward 1 was under esophagus, 2 and 3 was under stomach. But in Ajcc 8, now Seward 1 and 2, both of them are under esophagus, and Seward 3 belongs to carcinoma stomach. Okay? Now, you know what is Seward? If you consider G junction as 0 level, then there will be +5 to -5. Okay, and you add +1 above and -2 below. So +5 to +1 is Seward 1, that is a zone 1. +1 to -2. That is the true G junction, that is Seward 2, and -2 to -5. Are you getting this?
Yes, sir.
So that is Seward 3. So Seward 1 and 2 behaves like esophageal cancer, and the management is just like esophageal cancer. And Seward 3 belongs to stomach, and the management is a total gastrectomy. Okay?
Yes,
am I clear? Okay, Sat, please.
Yes.
Yeah. And in presentation, you have mentioned that weight loss is always an advanced disease. You see, in cancer is where, because of dysphagia, patient may have early weight loss. So weight loss may not always be a feature of advanced disease. And some of the patient may present with chest symptoms because of dysphagia, and sometimes because of reflux. Some of the patient may have chest symptoms, which may not be due to metastasis even. Okay. Otherwise, presentation is good. Okay. We can pass on to the last presentation. management of cancer esophagus by Dr. Anish Pandey. He is third year PGT from RKM Shivapur. Dr. Anish, you can share your screen and start.
Hello, good morning, sir. Am I audible, sir?
Yes, you're audible.
Yes.
Dr. Min, please share my screen. Dr. Milin. Is it visible, sir?
Yes, yes.
Good morning to all of you, sir. Respected seniors and my dear colleagues. Myself, Dr. Anish Kumar Pandey, third year junior resident, WIMS. I am going to present the seminar on the carcinoma esophagus, management and esophageal replacement and reconstruction. So we will start with the pre-treatment workup. Next slide, please. Before starting the definitive management, we will go for the pre-treatment workup of the patient for the definitive treatment. We will start with the history and the clinical examinations, routine blood investigations for the anesthetic fitness and assessment of the nutritional status of the patients, cardiac and the pulmonary workup, endoscopy and the imaging as previously discussed by my fellow colleagues. This is basically a rough idea of the how we proceed for the carcinoma esophagus. This protocol can be vary according to patient and subject to availability of the expertise and the resources. So CA esophagus, if there is a TNM staging of T1, and then if there is T1A and T1B, if there is T1A, we look for any evidence of the lymphovascular invasion. If there is no evidence of any lymphovascular invasion, we will go for the endoscopic techniques. And if there is a evidence of lymphovascular invasion, then we will go for the surgery. For T1B tumors, we will go for the surgery. And for T2 and above, or any T with N1, 2, and 3, we go for the neoadjuvant chemotherapy plus radiation therapy followed by the surgery. This can be vary according to patient. Next. Now, in the surgery, we divided the esophagus into the 3 levels: cervical, thoracic, and the gastroesophageal junction. For cervical tumors, the management is either pharyngolaryngeal esophagectomy, or we will go for the chemoradiotherapy. For thoracic, we divide thoracic in the 3 regions: upper thoracic, middle 1/3, and the lower thoracic. For upper thoracic, we have McEwan approach. For middle 1/3, we have Lewis scanner approach, and for the lower thoracic, we have Lewis scanner approach. For the gastroesophageal junction, next slide, please. As previously discussed by the sir, we have the Seward classification, type 1, type 2, and type 3. Sir has very beautifully explained the types. So according to 8th Ajcc, type 1 and type 2 is now considered as a esophageal, treated as same as we treat CA esophagus, and type 3 is treated as carcinoma of the stomach. Next, please. Now we will go for the definitive treatment. Early squamous cell carcinoma. Early tumor includes T1A. The risk of nodal metastasis is most important factor to consider in choosing the therapeutic options. Tumor with minimal risk of the nodal metastasis are amenable to endoscopic resection techniques. Endoscopic resection techniques includes endoscopic mucosal resection and endoscopic submucosal resections. Endoscopic submucosal resection has less chance of positive margins, more en bloc resection, and lower recurrence rate, but has high chance of bleeding and the perforation rates. Next slide, please. Now we come to the early adenocarcinoma and high-grade Barrett's dysplasia. For early adenocarcinoma and high-grade Barrett's dysplasia, the treatment options include intensive surveillance, mucosal endoscopic therapies, and the esophagectomy. Intensive surveillance carried out by the endoscopy. High-grade dysplasia is currently the only reliable marker of pre-invasive cancer. Finding of high-grade dysplasia is threshold for interventions. The option of endoscopic approach for high-grade dysplasia, Barrett's esophagus, and early adenocarcinoma includes endoscopic mucosal resections, photodynamic therapy, and the radiofrequency ablation. The esophagectomy is the only method to ensure complete eradication of dysplastic mucosa and frequently undetected invasive cancers. Next slide, please. In summary, in patients with high-grade dysphagia or early intramucosal cancer, treatment is indicated preferably with the endoscopic modalities. When histopathological findings of the specimen indicates more advanced disease, that is more advanced than even a multidisciplinary approach of management, as advanced stage disease should be considered. Next slide, please. Now we come to the advanced esophageal cancer. The surgical resection remains the mainstay treatment for localized esophageal cancer. Surgery with multimodality treatment is also the standard of care. The important aspect for better outcome after surgery depends upon the selection of appropriate patient for resection, choice of surgical technique, peri and post-operative care. The surgical options for CA esophagus depends upon the site of growth and can be divided as follows: the cervical esophagus, thoracic esophagus, gastroesophageal junction tumors. Now we come to the management of cervical esophageal cancer. The incidence of cervical esophageal cancer is 2 to 10%. Pharyngo-laryngo esophagectomy with or without adjuvant radiotherapy has been the gold standard of the treatment. The pharyngo-laryngo esophagectomy procedure involves cervical and abdominal incision and thoracotomy. A permanent end tracheostomy is created. As there is a high chance of mortality and morbidity, surgery is often not the first choice of the treatment. Therefore, the current role of surgery for cervical esophageal cancer is mainly for salvage after incomplete response or recurrent disease after chemoradiotherapy. Now we come to the thoracic esophagus. Thoracic esophagus is again divided into the upper, middle one-third and the lower. For the upper third extends from the thoracic inlet to the azygous vein. Here we will do the three-phase esophagectomy, also known as McKeown approach. It is an appropriate choice with the purpose of gaining adequate proximal margin. It basically involves right thoracotomy followed by the laparotomy for preparation of the gastric conduit, and lastly pull up to the neck for the esophagogastric anastomosis. For the middle one-third esophagus, it extends from the azygous vein up to the inferior pulmonary vein. Here we will do the two-phase esophagectomy, that is Lewis-Tanner approach. Next slide. Lewis-Tanner approach is stomach is first prepared by the laparotomy followed by the right thoracotomy when esophageal tumor and relevant draining lymphatics are resected. The gastric conduit is then brought to the chest for the esophagogastric anastomosis. For the lower thoracic esophagus, which extends from the inferior pulmonary vein to the crus of the diaphragm, we will treat the lower thoracic esophagus tumors by the same Lewis-Tanner approach. Now for the gastroesophageal junction tumors managed according to the Seward classification. As already discussed, Seward type 1 and type 2 are treated as a gastric carcinoma, esophageal carcinoma, and Seward type 3 is treated as a gastric carcinoma. Next slide. Now we come to the transthoracic esophagectomy versus transhiatal esophagectomy. In choosing transthoracic esophagectomy or transhiatal esophagectomy, there are several factors to consider, including the location and stage of the tumor, neoadjuvant treatment, and the intended extent of the lymphadenectomy. The transhiatal esophagectomy can be more safely performed for the distally located tumor, where dissection can be performed under visual control. If extended nodal dissection is planned for the middle and the superior mediastinum, transthoracic esophagectomy is preferred. Next slide. Now we come to the extent of resection and resection margins of the primary tumor. Curative R0 resection in esophagectomy entails clear resection margins, including proximal, distal, and adventitial margin for the primary tumor and radical clearance of the lymphatic drainage system. The extent of the lymphadenectomy for the two types of cancer is often different because of their biological behavior. The margin status we take for the proximal, we take 10 centimeter margin, and distally we take 5 centimeter margin. As lymphatics are running longitudinally, hence wide margin taken to prevent the skip lesions. Extent of the lymphadenectomy for squamous cell carcinoma. Lymphadenectomy for squamous cell carcinoma is performed by transthoracic approach, either open or minimally invasive. unless only a limited lower mediastinal dissection is planned. Different extent of lymphadenectomy for squamous cell carcinoma have been described. Standard two-field lymphadenectomy involves dissection of infracarinal lymphatic drainage system plus lymph node around the celiac trifurcations. The extended two-field lymphadenectomy involves standard two-field plus superior mediastinal lymph nodes plus right paratracheal and right recurrent laryngeal nerve lymph nodes. The complete two-field lymphadenectomy involves extended two-field lymphadenectomy plus nodes along the left recurrent laryngeal nerve lymphatic chains. Three-field lymphadenectomy involves the complete two-field lymphadenectomy plus bilateral cervical lymph node dissection. For Barrett's adenocarcinoma and gastric cardiac cancers, positive nodes are found only in the 0 to 6% cases, so lymphadenectomy is generally performed using a standard two-field approach. Now, we come to the choice of esophageal substitute. After surgery, we will go for the esophageal substitute. It can be taken from the gastric tube, colonic conduit, and jejunal loop can be used. Gastric conduit, an isoperistaltic tube based on the greater curvature with preservation of right gastric and right gastroepiploic vessels are taken. The simplicity of its preparation, adequate length, and robust blood supply makes it the first choice. The disadvantage of gastric conduit is postprandial discomfort, early satiety, acid reflux, and the gastric ulceration. The pylori drainage procedures, diet modifications, and the use of proton pump inhibitors and prokinetic drugs may be useful to prevent the postprandial discomfort or acid reflux. Next. Now we come to the colonic conduit. Colonic conduit provides long-term following functions. Colon can be used as a first choice of esophageal substitute as it avoids the problem of acid reflux and the stomach is preserved for its reservoir function. But the disadvantage with the colonic conduit is it requires 3 anastomosis, more blood loss, longer operative time, and higher anastomotic leak rate. Jejunal loops. When we apply jejunal loop for the reconstruction, it is known as modified Merendino procedure. It is used most frequently after distal esophagectomy and total gastrectomy for cancer of the lower esophagus and the gastric cardia. A Roux-en-Y configuration seems best as it prevents the bile reflux. Next. Now we come to the route of the reconstructions. Route of the reconstructions can be used as subcutaneous route, retroesternal route, orthotopic route. The subcutaneous route is rarely used because it is cosmetically unsightly. The orthotopic route of reconstruction maintains better nutrition status than the retroesternal route. The retroesternal route is preferred when resection is palliative, especially when post-op radiotherapy is planned. Next. Now we come to the complications after surgery. The overall complication rates ranges from 17% to the 74%. The pulmonary complication remains the most common and the serious post-op morbidity, including pneumonia and the respiratory failure. Measures to improve the respiratory outcome can be pre-op cessations of the smoking, chest physiotherapy, avoidance of recurrent laryngeal nerve injury, cautious fluid administration to prevent fluid overload, early ambulation, and the epidural analgesia. The most common surgical complications after esophagectomy is anastomotic leak. The most leaks are probably related to the technical errors such as tension between the conduit and the esophageal stump, ischemia of the conduit as a result of rough handling and the poor preparations. The intrinsic vascular perfusion of the stomach can be enhanced by ischemic preconditioning, whereby partial mobilization of the gastric conduit is later followed by the second stage anastomosis. Endocyanin green can be used intraoperatively to look for the anastomotic perfusion. Stapled anastomosis is popular for intrathoracic anastomosis, whereas hand semen technique is preferred in the neck. Another surgical complication includes chylothorax and the herniation of the bowel through the diaphragmatic hiatus, and both corrected by the surgical re-exploration. Other complications include myocardial infarction and the atrial arrhythmias. Multimodality treatment strategies includes radiotherapy, chemotherapy, and the chemoradiotherapy. The neoadjuvant radiotherapy has not been shown to increase resection rate or improve survival when compared with the surgery alone. Adjuvant radiotherapy of 50 to 60 Gray decreases the chance of the anastomotic recurrence. Neoadjuvant chemotherapy with 3 cycles of the cisplatin and 5-fluorouracil improves both progression-free and overall survival. A neoadjuvant chemoradiation plus surgery improves 5-year survival rate as compared to the surgery alone. Neoadjuvant chemoradiation does result in the more pathological complete response compared with the chemotherapy. Data on recurrence patterns showed that both local and the distant disease control were superior with the combined treatment. Various chemotherapeutic agents can be used as azathioprine, 5-fluorouracil, paclitaxel, docetaxel, irinotecan, gemcitabine, herceptin, bevacizumab. Now we come to the palliation. Endoscopic palliative treatment for more advanced tumor includes placement of the esophageal prosthesis, laser therapy, and the photodynamic therapy. The most common employed technique is insertion of prosthesis, especially self-expanding metallic stent, SEMS. The main problem with self-expanding metallic stents are stent migration, tumor ingrowth or outgrowth, and if placed across the GE junction, acid reflux is observed. But the placement of SEMS is still possible and achieve good palliation. Summary and the future perspectives. Significant improvement is evident in the management of the esophageal cancers. Advancement of the technology, proliferation of investigations and treatment modalities allows for precisely stratifying patients into various treatments. Surgeons play an important role in formulating treatment plan for the patients. Minimally invasive esophagectomy is now practiced in many centers with subject to availability of the experts. Next. Neoadjuvant chemoradiation integrated with surgery for advanced stage disease seems better than either chemotherapy or radiotherapy alone incorporated with surgery. The challenges for the future is for us to critically test our strategies in a scientific, unbiased manner and to explore other innovative treatments. Thank you.
Yes, so that was an extensive presentation. So tell us what is the 5-year survival of carcinoma esophagus?
Sir, 5-year survival of, sir?
Approximate.
Sir, actually the carcinoma esophagus patient presented late. So 5-year survival is usually 6 months.
5-year survival, you say in percentage. That means
yes, sir. Sorry, sir.
Today, if there are 100 patients of carcinoma esophagus, how many of them are going to survive in next 5 years? That is how you calculate 5-year survival. So it is to the tune of 15 to 20%. The case fatality rate is towards 90%. So it is that fatal a disease. Okay. So you tell me the role of chemoradiation, neoadjuvant chemoradiation. The only trial which you need to remember is this one, based on which you have decided that any tumor of more than T2 or any node positive disease should undergo a neoadjuvant chemoradiation before surgery. What is that trial?
Sir, cross trial?
Cross trial, right. So cross trial has shown us, see why I am saying the 5-year survival, because in cross trial it has been shown that patients who receive only chemotherapy versus a neoadjuvant chemoradiation followed by surgery, there is an increase of 5-year survival to the tune of 50% from 34% with only surgery. So no treatment, 20% is the 5-year survival. With surgery only, 34% 5-year survival. With chemoradiation followed by surgery, the 5-year survival increases to 50%. So that is why chemoradiation has now a big role in management of carcinoma esophagus. Okay, so tell us something more about minimally invasive esophagectomy.
Sir, minimally invasive esophagectomy implies the laparoscopic techniques like the thoracoscopy and VATS, video-assisted thoracic surgery, and laparoscopic approach for the abdominal preparations.
What are the advantages of minimally invasive esophagectomy?
Sir, less post-op complications, sir.
How about the lymph node dissection?
Yes, lymph node dissection.
There are some publications saying that lymph node dissection is not bad with minimally invasive surgery, because if you see the technique, the thoracic part can be dissected well, like open surgery.
Right, and especially with the advancement in robotic surgery, the esophagus has become relatively easier to deal with. And it's beautiful in robotic surgery to do a thoracoscopic esophagectomy. When most of the cases, be it McEwen or Ivar Lewis, we do a right thoracotomy. When do you do a left thoracotomy for a carcinoma esophagus?
So for Seward type 1, we will go for the
Right.
left thoracotomy.
So for Seward, we do a left thoracotomy to do a completion lower esophagectomy, basically. Okay. So
And
how do
now,
Yes.
now you have molecular studies in cancer esophagus also, and that has led to some innovation of some targeted therapies. That is also a newer development. What you study? What is the role of VEGF?
Sir, bevacizumab and all.
Yeah, vascular endothelial growth factor receptor. These are also now being studied in esophageal, particularly advanced esophageal cancers, where there is a role for targeted therapies. It's not now standard of care, but these are being studied now and coming up as a modality of treatment.
Right. How do you manage tracheoesophageal fistula?
It's an early or advanced disease.
It's an advanced disease.
Advanced disease. So the idea is to what? To palliate.
Palliation.
How to manage?
Tracheostomy, sir.
Tracheostomy, most of the times they will not help, because you know
Any
that,
role for stenting?
right.
Yes.
What stent?
Metallic stent. Metallic stent is preferred.
Okay.
SCM.
Before that, yes, sir. Please.
Yeah. Please carry on.
Before that, tell me, for a grade 4 dysphagia in a patient with carcinoma esophagus, if the patient is metastatic, comes to you with a grade 4 dysphagia, which one is your treatment of choice? Feeding jejunostomy, feeding gastrostomy, or esophageal stenting?
Sir, I will go for the esophageal stent.
What are the advantages of stenting over a feeding procedure?
Sir, feeding procedure may results in the aspiration. So stenting prevents the chance of aspiration. Hence, I will go for the stenting.
Because the feeding jejunostomy and feeding gastrostomy will help you in nutrition. But one big problem with esophageal growth is the saliva. So that will continuously go into the trachea. If you do a stenting, that problem will be solved. For tracheoesophageal fistula, in a case of esophageal carcinoma, routinely what we do is a stenting for both esophageal stent as well as a tracheal stent. Most of the times the problem is solved, but this is a temporary solution. Previously, the radiation was contraindicated in tracheoesophageal fistula because they used to say that the fistulization will increase if you apply radiation. But there are few trials which has come in last 5 to 6 years that chemoradiation in presence of tracheoesophageal fistula actually closes the fistula. So there is a role of radiation and chemotherapy in tracheoesophageal fistula. That is a new development. All right.
Okay. There is no question in the chat box. So anything else, Dr. Das, or you can conclude?
No, yes, sir. That's fine.
Yeah. So thank you all.
Thank you, sir. Thank you.
Thank you. Thank you all the speakers.
Thank you, sir. Thank you.